Hi, thank you. Thank you. And again, I'm really, really sorry and disappointed. But interestingly, in a way, I'm starting my presentation by sharing something about my personal experience. Because I was on my way back from my HIV clinic, but everything was fine, and I was in a very jolly, happy mood, and I slipped. And this is the first time that someone addressed me as an elderly lady, which was, apart from the physical pain, there was an emotional pain that I felt. This really is the beginning of a new journey for me. So I'm starting my presentation with saying that I have no any kind of disclosure. And the overview of what I want to discuss with you today is sharing much more briefly than what I originally thought the current landscape, because the speakers before me have already set clearly the landscape. I'm going to focus then on understanding what I think optimized care means, and then hopefully I have some take-home message for all of us to share. So my presentation is framed within the social determinants of health, and I'm not going to spend much time on this because the slide is really self-explanatory. I'm moving to the current landscape very quickly because all the speakers before me have said already much more and more eloquently what I was going to say, that there is highly effective antiretroviral therapy, which very often leads to low virological failure. There is, and I'm very pleased to report that there is greater and greater patient involvement, which means that our quality of life is improving and can improve. HIV-associated mortality is dropping. And so, in a way, we can argue that HIV in the old and aging population living with HIV is manageable. And the number of us living with HIV in older age is increasing. But at the same time, I think, as already speakers before me have highlighted, the clinical practice presents a different and possibly much more complex scenario. So HIV has increased the complexity of care for all of us growing older with HIV. And as we age, we are at increased risk of frailty and other geriatric syndromes. And as we heard just the speaker before me, adequately talking about polypharmacy and also the emerging of psychosocial needs. There is evidence, we suggest that there may be gender-specific challenges to address in the aging process. So there is an evident need for tailored health services reflecting a gender-specific perspective. I had made a quite detailed list of the components of care, but I want to kind of be spending less time than I originally thought, because I assume that I will repeat most of what has been, excuse me, said already. So in terms of HIV management, I think that I'm going to focus specifically, briefly, on the inadequate representation of older and aging people in HIV research. As we all know, in the early days, so I'm referring to the mid-1980s, early antiretroviral treatment were characterized by many side effects. And also the schedule were very complicated and complex. We experienced a very high field burden. Then clearly scientific advances meant that not only we had at our disposal many more options, but also we also have, and already the speaker before me mentioned this, we have now the opportunity rather to think about long-acting injectables. Now, if we think about old and elderly people living with HIV, and we then address issues such as frailty, sarcopenia, loss of muscles, then immediately we can start thinking that for most of us who are experiencing, for instance, sarcopenia, loss of muscles, then having an injection on practical level would be quite tricky. So, in other words, some of us will be or are already excluded. So maybe started thinking already how we can be embedded in clinical trials from the outset. I'm mindful of the fact that because we live, most of us, with many comorbidities, it is more complex, it is more difficult. In the same way, however, I'm advocating for older elderly people living with HIV to be included in clinical trials in the same way in which we have and we continue to advocate, although things have improved greatly, for women to be included in clinical trials. The management of comorbidities, I'm sure that all the speakers today have addressed this in so many different facets. And I understand and I'm very mindful that managing comorbidities is a great challenge for healthcare systems. But what I want to highlight here in terms of components of care is still within regions and within country, and the country I'm referring to the UK, but then I can make references to Italy, because that's also where I have plenty of experience and example to share. There is a disparity in care, which possibly could be addressed by exchanging information amongst health board and amongst clinicians as well. In terms of management of comorbidities, I also want to highlight, as well as what's been highlighted before. So, for instance, we are experiencing greater risk of diabetes, cardiovascular diseases, liver disease, chronic kidney disease, and so forth. But also, we don't talk a lot about visual impairment and how important it is for us that this is an issue that is addressed promptly. In terms of screening guidelines, much work has been done. And again, I can only commend, I'm sure many of us have done that already, Dr. Laura Walters, with what she has achieved in a very short period of time with regards to screening guidelines in relation to statins. But just to give a personal, make it this a kind of more personal experience, despite rapid guidelines just in existence, but despite the knowledge that we have about statin, as activists, but also as most clinicians would support, within Scotland and within England and the UK, there are disparities, and there are almost like different religious approaches to statin use. Some clinicians will suggest it's not time until it's too late. Some will suggest we'll try anyway and see what happens. It would be useful for us to have consistency in care. When it comes to difficulty ensuring appropriate treatment of multi-morbidity, again, most of us experience great healthcare, both at the clinic, but also in relation to general practice. However, it would be useful in terms of components of care that consistency is applied regularly and all the time. If conditions we are experiencing are requiring more advanced and specialist care, then we need to know who to approach, how and when. For all of us with sort of aging-related syndromes of multimorbidity, so with more than one comorbidity, often care delivery is piecemeal and kind of disconnected, increasing the possibility then of complication. In terms of components of care, I think that screening for aging-related syndrome often has some limitations still. I think this is important when I'm thinking about neurocognitive impairment as we're aging with HIV, to recognize that most of us as activists have been used to be in control of our relationship with the clinic, with the nurses, pharmacists, clinicians, so forth. Some of us are quite knowledgeable. And the idea that there could be a loss of power because we're aging, but also because of neurocognitive impairment, is clearly very scary and frightening. Being in charge of our healthcare is very important, and this contributes to our quality of life. I think it's important in terms of components of care that we start thinking about involving a geriatrician in the care of old and aged people living with HIV. My question would be when, at which stage? Can we do as we're aging? Can we wait? Do we need to wait? These are questions, and I don't have, unfortunately, the answer as such. Now, in terms of components of care, access to food and then housing and services are clearly more difficult with age. This is not HIV specific, but access to food, even before we go to the cost of living and so forth. Let me remind you that, for instance, not very often we talk about aging with HIV and dental care. So actually eating food sometimes is difficult. Not to mention that sometimes for some of us, it's difficult to have access to healthy food. The same is for housing and services. Then when it comes to socialization and behavioral health, again, socializing with others, and again, this is probably something that has been addressed many times already, becomes with age more and more difficult, irrespectively of the fact that we're living with HIV. That for those of us who are living with HIV, needs are complex, and opportunities to see others becomes much less frequent. Depression and substance abuse is an experience that most of us have had or have still. And the impact of stigma and isolation is still, sorry, I just went too fast. And the experience of stigma and isolation is something that we experience, but ages is a new experience for me, but is another layer of stigmatization. Women in the current landscape are not simply visited. Aging and older women live with HIV. Women, the proportion of women living with HIV getting older is increasing. Women living with HIV who are middle-aged or older are at higher risk of non-age-defining comorbidities. And women, as probably has been discussed already several times, are more likely to develop premature menopause. There are many challenges for older women living with HIV, medical challenges, which I'm sure have been addressed already, but psychological challenges. I mentioned ages, but also we do live still in a society which is fundamentally racist and misogynist. Menopause is clearly a defining moment for all women living with HIV, for all women, but in particular for women living with HIV, because we experience menopause much earlier than women who are not living with HIV. Some of the points here are for me just to remind the fact that we're not just navigating this landscape, but there are still stereotypes and assumptions about women in relation to our sexual health and our sexual desire, as almost if there is a cutoff point where sex is not something on our agenda as we age. But also, the research about women is very much focusing, or the assumption is that women are all heterosexual, and sometimes, quite often, I dare say, also healthcare providers reflect this assumption. There is not much work done, not many conversations about older women aging with HIV who are transgender women. Healthcare professionals, specifically outside the comforting bubble that is the HIV clinic, are referring to us as old, lovely lady. The language is very disempowering, so is the approach. Mental health for women living with HIV is still not considered, and we have to push hard and hard. Also, it's important that trauma-trained healthcare providers are available to women as we age. So let's try to understand what optimized care means. In order to develop this as the key point of my presentation, I had the opportunity to ask some of my friends, and you'll be pleased to see that in terms of socialization, at least I have 18 friends. I asked people I know who are living with HIV, what would it be the optimizing care that they can think of? What does it mean to them? The mean age of the people I got in touch with is 67, and I have to highlight this is not a kind of validated survey by all means, but it was a useful opportunity for me to set up this kind of conversation. I spoke to 15 men and 3 women. Most of the people I spoke to were white British born, and 3 women, 3 men were non-British nationals. Interestingly, and here already we start to see some divide, 2 women in the very limited sample that I can share with you never worked in their life. People who have been living with HIV for many, many years, several decades, have in some instances experienced the fact that it's difficult for them at a later stage in their life to approach the job market simply because of the lack of skills. Some of the people I spoke to, 8 men and 2 women, have had some sort of support in terms of they either live with a partner or they had a partner. So what does it mean to you, optimizing care? First of all, it's about having all care in one place. All the people I spoke to, they clearly evidence the fact that mental health is for us a key issue. And so is stigma, but so is poverty and isolation. Despite what I said earlier, the most people I spoke to had a partner, and all the people I spoke to have, in their own words, a very successful and fulfilling social life. So I've just put this in a different context, and you can see that poverty, stigma, and isolation are really standing out. So let's try to understand briefly what optimized care means for women. What I've done in order to try to answer this question, I look at the evidence through the existing literature. And again, some key points are worth highlighting here. Mental health, interpersonal violence and abuse. Most women who are or are experiencing or had experience of violence and abuse, in many studies, and even out with the experience of living with HIV, still do live with their abuser as they grow older because of lack of opportunity to support themselves financially otherwise. Old and aging women live with HIV fundamentally live in poverty. And to the experience of poverty, we add the experience of the difficulties in sustaining, in some instances, a migration status, which then allow women to work. Most women, although they're older, still have caring responsibilities, which is an added burden. I try to answer this, the question about optimizing care in a different way. So care for old and aging women who live with HIV, it seems to me, by talking to some women, by referring to the existing literature, is very much about in one place, which is the HIV clinic. So there are different perspectives. Same HIV care from different approaches because we're all different, or different HIV care according to specific needs. Or another option, another opportunity, another viewpoint would be geriatric care for older and aging people living with HIV. A point I want to make here is that optimizing care is more than just a body of theory and intervention methods. And it's impossible to separate how we can offer optimized care from why we do offer optimized care. But clearly, this is a conversation that is much wider than within the specific focus of HIV. But when we talk about changing behavior or changing community structure or building community capacity, and we as activists, we try to do this all the time in conjunction with our care providers. This changing cannot be separated from our ideas about what is a good community or a good society. Again, it's a wider conversation to have. In terms of optimizing quality of life and care, the balance is always between effectiveness, which I'm referring here in terms of cost effectiveness, and quality of life. Often the message that comes across is healthy aging, and the burden is on us on exercising, on healthy foods, reducing stress, and so forth. But in reality, we do experience anxiety, depression, despair, boredom, loneliness, and so forth. So there are two different contrasting messages here. I think it's important to highlight, in terms of continuity of care for older persons living with HIV, that, for instance, clinicians and nurses retire or change jobs. And new clinicians and nurses are the generation of U equals U, and antiretroviral treatment that works. And nothing else, in terms of most of the new generation is capable of living a perfectly successful and healthy life without thinking so much about comorbidity and so forth, where most of us cannot. Support network clearly changes, but also HIV services are not there anymore to support us, especially the older population. Stigma has never disappeared, but age is greatly experienced. Financial insecurity means not just that we experience financial insecurity, but also that the system that supports us is experiencing financial insecurities. There are challenges, clearly. The first challenge I identified is the one in relation to geriatricians. They have no extensive knowledge of HIV or specific issues related to older people living with HIV. They don't have the experience of interacting with most of us who are expert patients and advocates. There is still very much attitude and prejudice related to HIV outside the beautiful bubble that is the HIV clinic. And most of us have experienced many times in many healthcare settings stigma and discrimination and prejudice. Challenges are also in terms of creating optimal programs for older and aged people living with HIV because of the complexity of care that we experience. Also, challenges are to be seen in geographical and cultural location in terms of resources, which can influence what older and aging people living with HIV prioritize and what we feel we need for our healthcare. But there are also suggestions that I would like to offer. In particular, the active involvement of all of us in decisions about priorities and structure program, development of screening tools, but also incorporation of the concept of optimizing excuse me, functional ability into the primary care model. Creation also of guidelines that assist in the management of multimorbidity in for all of us that are aging with HIV. Integration of care and other services. I think that it's important to start thinking about adaptation of geriatric social programs for all of us aging with HIV as a kind of intermediate step. The inclusion, as I mentioned already, of older and aging people living with HIV in antiretroviral drug trials, and the preparation for long-term care needs to maintain the opportunity for us to be in the community and to create safe and caring environments in long-term care facilities. I think for me, as an observer, but also as someone with experiences, because this is my lived experience, I think what I find interesting and fascinating is that there are experiences of good practice. I'm thinking about the Silver Clinic in Brighton or the Metabolic Clinic in Italy, in Modena. I think what is lacking still is that the exchange of information, the exchange of knowledge about good practice, both among us, but also amongst clinicians and healthcare practitioners. I think that, again, access to good nutrition, exercise, socialization, safe housing is really very important at local level, but also at wider level. Healthcare systems and their payment mechanisms are not yet flexible to underwrite these programs, and government, local, national, and international level to support different models. I want to finish by mentioning the Glasgow Manifesto, which is a document that has been combined by the International Coalition of Older People with HIV. The Glasgow Manifesto is very important to us, but to all of us who are working in the field and supporting older aged people living with HIV, because pushes for the development of new models of care for all of us aging with HIV. It's about raising awareness, and also it's about responses from community which are age-affirming, addressing ages, and increase intergenerational understanding. what is still difficult and what we're experiencing as we're aging with HIV is that the younger generation of those who are living with HIV have no interest in learning, for instance, about aging with HIV and comorbidities. So there is a kind of disconnect between the old and the young generation, which does reflect what happens in society as a whole anyway. Changing policy is important to respond to the unmet housing, food, and resource needs of all of us living with HIV who experience disability. We don't talk enough about disabled bodies within our community. It's important, and I'm speaking as a person living with HIV, but also as a social scientist, as a researcher. More research is important. And specifically, I was thinking about asking some of my friends what they think about optimizing care. I think a piece of work which has more significant academic relevance is important, and asking both clinicians, healthcare practitioners, and those who are living with HIV, what does it mean in terms of optimizing care would be an interesting piece of research to develop. Including all the people living with HIV in decision-making about HIV response is very important. The Glasgow Manifesto is very much about the fact that we all deserve age-friendly and age-affirming information, services, and support that consider not only the impact of our HIV status, but also our gender identity, sexual orientation, race, and ethnicity. And this is the link to the Glasgow Manifesto. There is some sort of take-home message here. Poverty is what people aging with HIV experience the most. This is possibly the most frightening of the all experiences. Optimal HIV care is achievable if we abandon the paradigm that one approach fits all. But also, within this approach, people's needs are different at different stages, so I might have different needs that I had even 6 months ago. And I think it's important to allow flexibility. It's paramount that there is a space for community involvement. Peer support is the key. And women are particularly disadvantaged as we age with HIV. Thank you for listening to me. And again, apologies for not being in person. I would have loved to be there. Thank you.